Welcome to part 3 of chapter 45. We're going to discuss intracranial infections. Intracranial infections. Central nervous system has limited response to injury. May be difficult to determine the cause from clinical manifestations. Laboratory studies are required to identify the causative agent. Inflammation can affect the meninges, the brain, or the spinal cord. Let's talk about bacterial meningitis. It's an acute inflammation of the meninges and the cerebral spinal fluid. There's a decreased incidence since the introduction of the Hib vaccine in 1990. It can be caused by various bacterial agents such as Streptococcus pneumoniae, Neisseria meningitis, Group B Streptococci, Staphylococcus aureus, and Escherichia coli, also known as E. coli. That's easier to say. And then we have transmission, droplet infection from nasopharyngeal secretions. And then we have appears as an extension of other bacterial infection through vascular dissemination. And then organisms then spread through the cerebral spinal fluid. And then there's an increased risk with the number of contacts. And then, of course, there's the seasonal variation, late winter and early spring. So looking at the clinical manifestations, review box 45-4 on page 1440 of your textbook. Diagnosis and treatment. Diagnostics, a lumbar puncture is definitive diagnostic test. Culture and sensitivity are needed to identify the causative organism, and the child with bacterial meningitis will also have an elevated white blood cell count. A blood culture is advised even when the child does not have a positive CSF culture. Nose and throat cultures may also help with diagnosis. Therapeutic management. Acute bacterial meningitis is an emergency that requires early intervention. Care typically occurs in an ICU. The initial therapeutic management protocol is listed on page 1440 in your book. Isolation precautions. The child is placed on droplet isolation. Then we have antimicrobial therapy. Until the causative organism is identified, a broad spectrum antimicrobial that is used to treat the most common causes of bacterial meningitis is initiated. You want to start antibiotics as soon as they are ordered. Once the CNS results are obtained, the medication or dosage may be adjusted as necessary. Treatment with IV cephalosporins is typically initiated first because it promptly sterilizes the CSF and reduces the risk of hearing impairment that is associated with other antimicrobials such as gentamicin. Restricted hydration. Maintaining fluid balance is a primary concern, so the child may be placed on a fluid restriction until serum sodium levels normalize. It measures to decrease the ICP and may be implemented during this time as well. And then long-term fluid restriction is not a standard of care. Maintenance of systemic shock by restoration of circulatory blood volume and maintaining electrolyte balance. Seizures can occur during the first few days of treatment and are controlled with appropriate anti-epileptic drugs. Because hearing loss is common, the child should undergo hearing testing 6 months after the illness resolves. Prevention. Vaccines are available for certain types of meningococci and for the Hib. Children are routinely vaccinated with Hib vaccine starting at 2 months of age. Routine vaccination with the meningococcal vaccination is at age 11 and older, although children ages 2 to 11 may be immunized if they are at particular risk. The pneumococcal conjugate vaccine, PCV, is now recommended for all children beginning at 2 months of age as well. You want to look at page 1442, your evidence-based practice, children with bacterial meningitis and preventative vaccines. So for care management, keep the room dimly lit and as quiet as possible to keep stimuli at a minimum. Position the child in a sideline position for comfort. May or may not want a pillow. Avoid actions that increase pain, such as moving the child's head. Nursing care is determined by symptomology. Observe vital signs, level of consciousness, output, neural status periodically. Hydration and nutrition is determined by the child's status. They may be NPO or require IV hydration. Provide support to the family. Let's talk about viral meningitis. Causative agents are principally viruses, including the arbovirus, the herpes simplex virus, the cytomegalovirus, the human immunodeficiency virus, and the adenovirus. Diagnosis is based upon a CSF finding. Onset is abrupt or gradual. Manifestations include headache, fever, and malaise. And treatment is primarily symptomatic. Let's talk about encephalitis. Etiology. It's an inflammatory process of the CNS with altered function of the brain and spinal cord. There's a variety of causative organisms, direct invasion of the CNS by a virus, post-infectious involvement of the CNS after a viral disease, and then mosquitoes and ticks are typically the vectors. A diagnosis is made based on clinical findings and identification of the virus if possible, and an EEG may be helpful in the diagnosis. So let's review some symptoms. Manifestations can range from mild to severe. They include malaise, fever, headache, dizziness, stiff neck, nausea, vomiting, ataxia, speech difficulties, high fever, stupor, seizures, disorientation, spasticity, coma, ocular palsies, paralysis. So take a look at box 45-5 on page 1444 of your textbook. Okay, let's talk about therapeutic management. Usually they're hospitalized for observation. It's a supportive treatment. We do antipyretics for fever, encourage hydration. IV hydration may be necessary. You want to place the child in seizure precautions. You want to encourage rest. ICP monitoring may be required. Follow-up care with reevaluation and rehabilitation. In very young children, possibility of having increased neurologic disability. And then, of course, nursing care is the same as for any child that is unconscious or has meningitis. Rabies. Rabies is an acute infection of the central nervous system. It is caused by a virus transmitted by saliva of infected animals, such as skunks, raccoons, bats. Could be from dogs too. Virus multiplies in muscles and infection is fatal if it's untreated. Incidence in humans is highest among those that are less than 15 years old. Therapeutic management. We do the inactivated rabies vaccines, globulins, and thorough cleansing of the wound. Passive immunization with human rabies immunoglobulin as soon as possible. And then after exposure, we do the human diploid cell rabies vaccine. There's REYE'S syndrome. It's a disorder defined as toxic encephalopathy associated with other characteristic organ involvement. Characterized by fever, profoundly impaired consciousness, and disordered hepatic function. There can be elevated serum ammonia levels that tend to correlate with the clinical manifestations and prognosis. Cause is not well understood. Most cases follow common viral illnesses such as influenza and varicella. Potential association exists between aspirin therapy for fever and development of REYE'S syndrome. We have the diagnostic evaluation. You could do the liver biopsy, which offers a definitive diagnosis. For therapeutic management, early diagnosis and aggressive supportive therapy is very important. Care is similar to the care of any child with an altered state of consciousness. Look on page 1424 of your textbook. And then prognosis and recovery is very good in view of the gravity of the disease. This concludes part 3 of chapter 45.